morning. Good morning, everyone. Thank you for joining the New England Nursing Home Quality Care Collaborative. My name is Janet Robinson with the New England QIN-QIO, and this is the CDI Management in Post-Acute Care webinar. Before we begin the program, I have just a few housekeeping items to review. This webinar will be recorded, and the presentation will be available within a few business days. The phone lines will be on mute for the duration of the presentation. We ask that you please do not put your line on hold. If you have a question at any point throughout the presentation, please enter it in the chat panel to the right of your screen. Please make sure to send your comments to all participants. Joyce LaForge from the QIN-QIO team here in Rhode Island will be monitoring and responding to questions and comments in chat. We'll also have a little bit of time for questions at the end of the presentation, and we'll open the lines back up. Lastly, if you find that the presentation is a little bit cut off, please use the plus or minus icons in the top right of the presentation window to adjust your screen accordingly. Here are the objectives for today. Today's presentation is a pre-recorded video from an infectious disease physician. Her name is Dr. Robin Jump, and she does a wonderful job of reviewing material we may already know, as well as introducing new information. The video is in two parts. Both will be presented today for a total viewing time of approximately 44 minutes. I mention this so you don't sign off when Part 1 ends, because Part 2 will begin almost immediately. Let's get started. Hello, and welcome to CDI Management in Post-Acute Care, Part 1. My name is Robin Jump. I'm an infectious disease physician at the VA in Cleveland, Ohio. I'm also a case investigator at the university. My focus of my academic research is on antimicrobial stewardship in older adults, putting those in long-term care, and also on CDI. That's what we're going to talk about today. Here are my disclosures. And let's move on to a brief overview. So we're going to talk in this Part 1 session about pathophysiology and risk factors for C. diff, and we'll move on to diagnosis and treatment and infection control and prevention in the second part of the talk. So speaking with pathophysiology, and let me start by showing you on the left-hand side of the screen an actual picture of C. difficile. This is a gram stain of C. diff, and you can see that they are rods. And within each of those rods is a deep portion, which is the vegetative part of the bacteria, kind of the living and toxin-producing part, and that purple part is the spore. And we'll come back to that at a later point. The spores tend to hang around for a long time. Let's begin by talking about clinical disease. So C. diff in general can be divided into three categories: non-severe, severe, and severe complicated. Most people get better from the disease, and for a while they'll be an asymptomatic carrier. They'll still have the spores that are being shed out of their rectum and out of their skin. And with time, those spores go away, and that person goes from being an asymptomatic carrier to having no C. diff, they're healthy, recovered, and all is well in the world. Some people don't develop the disease and will die from it. And we have a significant number of deaths each year, estimated from 25,000 to 50,000 deaths annually. And then there's also an outcome which is most common among older adults, which is recurrent disease, where people get better and things seem to go back to normal, and then in a few days or a few weeks after stopping medicine for C. diff, the symptoms come back. And this can happen again and again. And it's usually non-severe C. difficile, but it's very burdensome to the individual, the people that take care of them. It really disrupts their life. They can't leave the house sometimes. And this is becoming a significant problem for older adults, especially. So let's talk about how people become sick with C. difficile. This is a picture of an intestine. And over the left-hand side of the slide is the normal microbiome.
And what I'm trying to show you in there is that it's a robust and diverse population of bacteria, with the little blue dots in the oval arm. And, of course, in the real gut, there's hundreds of different species and millions upon millions of bacteria. So when someone is exposed to systemic antibiotics, it reduces both the number of bacteria and reduces the species diversity. Now, under those circumstances, if someone who's been on antibiotics is exposed to C. difficile before their gut has been able to recover, which can take weeks to months, the C. difficile spores that they ingest can find a place to live within the gut. And those spores then can germinate and become vegetative forms, which are those little brown clouds there. And those vegetative forms in turn make toxins A and B, and those toxins are what make us sick. There's many risk factors for C. difficile, and as we've already mentioned, antibiotics is the most important risk factor. And it turns out that even if the individual themselves doesn't take an antibiotic, the facility antibiotic use will promote C. difficile transmission. This is a 4-year retrospective cohort study that examines patient and ward-level risk factors among individuals. This is in an acute care hospital. And what they found is that for every 10% increase in antibiotics used on a single ward in the facility, the relative risk for the patients on that ward increased by 1.34. And so what happened there is that even if someone didn't take an antibiotic, they were still at increased risk of getting C. difficile. And the take-home message here is that antibiotics put the entire population at risk, even those who aren't getting exposed to them. And the more that an individual is exposed to antibiotics, that increases their risk of C. difficile infection. There was a study done of almost like 500,000 adults that were admitted to 14 hospitals over a 2-year time frame. And of those, less than 1% developed C. difficile infection, so this is about 2,600 patients, which is still a huge number of patients to look at. And the investigators of this study looked at the relative risk of getting C. difficile by rating them by the number of antibiotics to which people were exposed, or the class of antibiotics. So exposure to one class increased the relative risk of getting C. diff about 2-fold. And then when someone gets exposed to 2 classes of antibiotics, the relative risk goes up to 3 to 4. And then as we add on more and more antibiotics, that risk seems to go up just a little bit more. And this is a pretty common scenario when someone's in the hospital or in long-term care. They'll start off with an antibiotic for one thing, let's say concern for a urinary tract infection or pneumonia. And if they don't get better, or if there's urine culture that comes back, or there's a new provider that comes on, there'll be a class switch of antibiotics, which means that we're essentially doubling that person's risk for C. diff within just by a medication change. And these are something that this is an avoidable factor. So steps that we can all take to reduce the risk of C. difficile are to cut back on antibiotic use. And first and foremost is avoiding antibiotics whenever possible. We need to change the paradigm for antibiotics as being a just-in-case measure to something that we only use when necessary, only when necessary. And one way that we can talk about this among ourselves as healthcare providers and to residents or patients and to their families is to talk about careful observation. And we've been calling this watchful waiting, and I'm on a one-woman campaign to turn this into a different term, which is careful observation. The idea being that when we say watchful waiting, we talk about this as we're just sitting back and kind of waiting around, and that's not the message that we want to convey, and indeed it's not what we're doing. When we're doing careful observation, when we're deciding if someone really needs antibiotics, we're doing more frequent vital signs, we're offering oral hydration, we're doing supportive care measures, and giving them time to show us if they just need a little bit of TLC to feel better, or if there is something that needs an antibiotic to treat it. And if we do careful observation, people usually let us know in 6 hours or 12 hours or 24 hours if we've made the right choice. And it's not a one-time decision. That's why we keep observing and we keep revisiting the decision to wait or not start antibiotics. When we must use antibiotics, 3 things that we can do are to use shorter courses, to choose neurosuction agents, and they'll also choose agents that have less excretion into the GI tract. So shorter courses, for example, community acquired pneumonia can usually be treated with a 5-day course of antibiotics. Most common infections that we're treating, especially among older adults, should be 7 days or fewer. Another strategy is to choose narrow-spectrum agents. For example, when there's concern for urinary depression, we often turn to fluoroquinolone as a first choice. But it turns out that Bactrim and nitroglycerin, which are both more narrow-spectrum agents, are usually equally as effective, and they have a less devastating effect on the GI tract. And that also hits the last point, too. Bactrim and nitroglycerin are both concentrated into the urine and tend not to undergo all that much GI metabolism. And that's a reasonable strategy to use to try to prevent C. diff, or at least reduce the risk. Moving on to the next slide. Advanced age is the second most important risk factor for developing C. difficile infection. This became very evident when the epidemic strain emerged around 2004. This is a graph that shows time in years along the x-axis on the bottom, and along the y-axis is the number of cases per 10,000 people in the population. Looking at the black line, that shows everybody in the population. The green line shows people that are aged 65 to 84, and the red line on top is people that are 85 years or older. So C. difficile was always a disease of older adults, and when the epidemic strain came out about 10 years ago, older adults were much more affected by this. In this clip, there's also age-related vulnerability. In 2010, greater than 90% of the deaths due to C. difficile infection were people 65 years or older. The reasons for this involve the immunosenescence that happens with aging, and this manifests as a poor antibody response to C. difficile, where people have that poor antibody response that correlates with infection, and it also appears to correlate with increased risk of recurrent disease. And in general, older adults have a less diverse and a less resilient gut microbiome, which also makes them more vulnerable. So for advanced age, the things that we can do are really not much. Until we find a fountain of youth, we're stuck with addressing the things that we can address, which for the moment is antibiotics. Other risk factors for C. difficile include, not surprisingly, previous hospitalization and being a resident in a long-term care facility. And the reasons for this are antibiotic exposure, and also because it's where people with C. diff go, which means that people at these institutions are going to be exposed to the C. difficile spores. Not surprisingly, underlying disease severity and low albumin also contribute to the risk of C. difficile. And there's not much that we can do about those, but we do have the possibility to manage gastric acid suppression. This turns out to be a pretty significant risk factor for recurrent disease. There was a study done and published in 2015 in Internal Medicine, in which the authors looked at hazard ratios, not ration as it says in my slide, for getting recurrent disease. So age older than 75 years, proton pump inhibitor use, which is PPI, antibiotic re-exposure, and length of stay all contribute to the risk of C. difficile infection. The authors then went on to explore more in depth what were the indications for proton pump inhibitor uses. And for over half the patients, there was no indication. They were just on it because they were on it, and they didn't actually have GERD or gastric esophageal reflux disease or any other risk factors that would make them need this. Some people had an age older than 60 years with 2 other risk factors that required them to have a proton pump inhibitor. Some had a history of C. difficile, and some had GERD in the previous 90 days. But over half of those folks had no reason for their proton pump inhibitor. So this is an opportunity for all of us to question someone really needs that medicine if we see it on their list. So steps that we can take to reduce other risk factors: stop PPIs unless they're truly needed, and avoid antibiotic re-exposure whenever possible. And the worst offenders for antibiotics that contribute to the risk of C. difficile are clindamycin, fluoroquinolone, and 3rd and 4th generation cephalosporins, the ceftriaxone, epipene, the Difficile, among others. So take-home messages from part 1. Further, antibiotic exposure is the main risk factor for C. difficile infection. Antibiotics disrupt the gut microbiome, which is an important and overlooked form of host defense. And that proton pump inhibitors appear to increase the risk of recurrent C. difficile infection. Before we end this segment of the presentation, I'd like to thank you for listening, and I also want to thank all of you for the work that you're doing on the front line to take care of our patients and our residents, and to do that, all the work that you're doing to reduce the risk of C. difficile. Thank you. Hello, everybody, and welcome to CDI Management and Post-Acute Care, Part 2. My name is Robin Jones. I'm an infectious disease physician at the VA in Cleveland, Ohio, and I'm also a member of the faculty at Case Western Reserve University. My academic interests are antimicrobial stewardship in post-acute and long-term care, and also C. diff prevention in that same population. Here are my disclosures. And in Part 2, we're going to focus on diagnosis and treatment of C. difficile infection, as well as infection control and prevention. So diagnosis and treatment. Let's review diagnostic criteria for C. difficile. C. difficile can be divided into 3 categories: non-severe, severe, and severe complicated C. difficile. The criteria to diagnose non-severe C. difficile are to have at least 3 liquid stools per day. A lot of people will say they have diarrhea, but that it can mean very different things to different people. Sometimes it means that they're having more stool than they used to having. Sometimes it means they're having loose stool. The criteria for diagnosing diarrhea that's related to C. diff is that the stool must take the form of the container. Second criteria is that they have to have a positive test for C. difficile. These tests vary as to when people are using where, and this is a particular area of debate and discussion right now among people who think about this a lot. But usually within a healthcare facility or network, there's just one type of test or one type of testing algorithm, and based on the last 5 years or so, only one sample of stool is necessary to do that test. In the old days, we used to have to send 3 stools over 3 days, and that's no longer the case. So for people that have non-severe C. difficile, we can definitely consider managing them outside the hospital, so either in a nursing home or even at home, depending on the situation. For people that have severe C. diff, in addition to the positive test and the 3 liquid stools, they'll also have an elevated white blood cell count of greater than 15,000, and they'll also have an elevated creatinine. The formal criteria is 1.5 times above their baseline. I think the working definition that I use is just, do they have acute kidney injury of some sort? And these are people that are initially managed better in acute care than outside the hospital. And finally, for severe complicated C. difficile, these are people that are clinically unstable. They may have an illness, so they're actually not able to show diarrhea. They'll have a toxic megacolon in some cases. And these are the patients that we're thinking about a possible ICU transfer. These are people that may require surgery or colectomy, so they need a surgical consult first, and then maybe an infectious disease consult afterward. And in these people, the recommendation is to monitor serum lactate and their white blood cell count as the management is being considered. So treatment of non-severe C. difficile infections involves, and I forget this all the time, and I think a lot of us do, the first thing that we all need to do is to stop the antibiotics that put them at risk for C. difficile in the first place. If it's still going, and if we can. The recommended treatment based on 2010 guidelines is oral metronidazole. And if somebody is on warfarin, then oral vancomycin should be the first-line treatment. And the reason for this is that metronidazole can increase the effect of the warfarin and lead to an increased INR. And I just want to emphasize, what I'm showing you now is based on 2010 guidelines that are published through the Infectious Disease Society of America and Society of Healthcare Epidemiology of America. There are revisions of the guidelines underway, and I keep waiting for those to come out. So we'll keep going with the 2010 recommendations that we have at the moment. One thing I also want to emphasize is that there is no need to do a test and cure. After someone has been sick with C. difficile and once her stools return to normal, they'll continue to shed the C. difficile spores for days or weeks, sometimes even months, after their stool has gotten back to a normal or perhaps sometimes a new baseline. If we keep testing those people for C. difficile, we'll find it, and that puts us in the bind of, do we keep treating or do we let it go? So a better approach to not do a test and cure is to go by clinical criteria to know if someone's getting better or not. And it's usually fairly evident that their stool has gotten back to some semblance of normal. It may take, even after the C. diff has been treated effectively, it may take weeks to months, sometimes a year for someone's stool to return to what it once was. This is unfortunate. People often need to be counseled through this, and sometimes need to do other medications to help them, and my preferred agent here is fiber. It helps bulk stools up and therefore can slow down the transit time. For people that have recurrent disease, again, we try to stop the inciting antibiotic. For the first recurrence, the treatment of choice is to repeat metronidazole. For the second recurrence, this is when people go to oral vancomycin. And if we get past the second recurrence is when we start getting creative, might be the way to describe it. And we do oral vancomycin, sometimes people do oral tapers. Or, as I'm sure that all of you are aware, there is now a whole host of new treatment options that people are exploring and using. One of them is fidaxomicin. And this is a relatively new antibiotic, and it's after they get C. difficile spores, the C. difficile vegetative forms, but it seems to spare other members of the gut microbiome. And the treatment outcomes for primary disease, or the first infection C. diff, are equivalent to vancomycin. But fidaxomicin has an advantage that it appears to reduce the risk of recurrent disease. What I'm showing you on the bottom part of the slide here are molecular structures of different antibiotics. So the antibiotic in the right side of the slide on the top part, the higher one, is penicillin. Below that, in the bottom right corner of the slide, is metronidazole. And then that great big thing that takes up the entire middle of the bottom part of the slide is fidaxomicin. And there are 3 6-carbon rings in there, and then there's a huge ring-like structure in the middle. And this is how I remember that fidaxomicin is called a the member in the class of macrocyclic antibiotics. I think it's that huge ring that makes it the macrocycle. One of the disadvantages of fidaxomicin is, of course, its cost. So on this slide, I'm showing a cost comparison of the 10-day course of fidaxomicin, which in 2013 cost about $3,300. Oral vancomycin capsules for a 14-day course is about $2,000. What we do at the facility where I work is we take the vancomycin that is made to go into somebody's vein, as IV vancomycin, and compound it into 100 milliliters of, I think it's D5W, divide that into 8 syringes, and then give that to patients. And that, for a 14-day cost, is less than $1 a dose. We're looking at $40. And metronidazole is equally inexpensive at $30 for a 14-day course. So sometimes this is why people wind up using the less expensive therapy, very reasonably so. We now have a whole host of new treatments that are still being developed and worked out and being made available. And the one that seems to capture all of our imagination is fecal microbiota transplant, or FMT. And this is administration of feces from a healthy donor to someone that's been suffering with C. difficile. And for those of you that have cared for people with C. diff, you know that they will do anything to get better, including an FMT. And this is an amazing treatment. People have stick resolution in 1 to 2 days. And in one of the early clinical trials that looked at this, there was a 93% cure rate with 1 or 2 treatments. And I can think of a few things that we do in medicine that are this effective. There's a small series that looked specifically at older adults that were 80 years and older. He had 10 of them had skin resolution. So again, it was 80% efficacy among that group. And just for full disclosure, that picture on the left is actually just a glass of chocolate milk, which you want to have a look at the same way again. So we moved on from fresh fecal microbiota transplant to using frozen fecal microbiota transplant. that's a chocolate ice cream. And this was a study that was a randomized, non-inferiority study of 232 adults with the average age of about 73 years that had refractory C. diff. They had recurrent multiple episodes of C. diff. And someone took frozen fruit salad and did a fecal microbiota transplant and found that it works as well as a fresh transplant. And this opens up the possibility of doing self-donation and also opens up the possibility of having stool banks so that people can get treatment when they need it as opposed to when they can find a donor. And this is a cost-effective and well-tolerated strategy. So even beyond frozen stool, we're now moving into an era of food pills. And this is now being tried with oral, capsulized, frozen fecal microbiota. The capsules are stored at -80 degrees Celsius, and each treatment is made from a single donor. And the pills themselves are really well encapsulated. They don't look at all like a cup of Easter egg on the left-hand side of your slide. They are put in several layers of gelatin capsules as in part for aesthetics, but that's also in part to make sure they get through the stomach and into the intestine, which is where they're expected to happen. But in early trials, about 20 patients with ages that range from 7 to 90 years. And they took 15 capsules a day for 2 days, and 14 responded to the first treatment, and 4 to a second treatment for a 90% cure rate, which is just amazing. This is still a relatively new and somewhat experimental treatment, but it's working, and I think that we'll see this expand. And there's now people that are doing freeze-dried food pills. And what I want to show you in this study is the change in the gut microbiome. So this is a case report of a 46-year-old woman with Crohn's disease who developed refractory C. difficile infection. Let me walk you through the slide here, or the graph on the left. So the y-axis is the relative abundance and proportions of different species of bacteria, different families of bacteria. The identity isn't important. What I want you to see is the change in the ratio of the colors. So the first bar here on the left, D, is for donor. And then the second one is donor frozen, that's the DF. The third bar, that's mostly green, is the microbiome of the 46-year-old woman prior to getting the fecal microbiota transplant. And then at 3 days, 7 days, and 14 days, her microbiome changed dramatically. There's a huge increase in the purple and a drastic decrease in the green. And she got better. And with the freeze-dried food pills, we're now able to actually have people do these treatments at home, which means that we're entering an era that might see a re-envisioning of a slogan from a company that we might all know. Let's move on now to infection control and prevention. And we're going to start by talking about nursing home onset C. difficile. This is a study that was done by my master, Curtis Oski, who looked at the time from admission to a long-term care facility to see this onset. So along the x-axis on the bottom are weeks from admission to one of our VA nursing homes. And along the on the y-axis is the number of patients. And most of our residents developed their C. difficile within 5 weeks of being admitted to the nursing home. And we consider them to be hospital-associated long-term care facility onset C. difficile. The reason why we consider them hospital-associated is because they all came from the hospital, and that's also where their exposure to antibiotics happened, after the initial insult to them occurred. And then when they came to the long-term care facility, that may have been when they were exposed to spores, and then became fecal C. difficile. And as you can see by the graph, when people have been in a nursing home for a while, their risk of C. difficile is significantly decreased. We have already people acquiring C. difficile if they've been in a long-term care facility for several weeks. And this just makes the point that if the exposure to C. difficile spores in that early time after transfer to the nursing home, that got people sick with this disease. And that becomes an argument for infection control as being a principal way to prevent C. difficile infection. C. difficile spores can be recovered months truly months after it's left on the surface. C. difficile spores are difficult to kill using routine cleaning agents. So quaternary ammonia compounds, which most people are using in hospital and nursing home cleaners, aren't effective against C. difficile spores. What is effective is a 1 to 10 solution of bleach that has to be made up fresh every 24 hours. And unfortunately, that's really corrosive. There are sporicidal agents that have to say sporicidal that are available for cleansing within a hospital or long-term care environment. And unfortunately, these are expensive, but they, like the bleach and the decorrosive, but they certainly are available and should be used to do routine cleansing for people that have recent C. difficile. The other thing that a lot of us didn't appreciate is that C. difficile spores are shed onto not only the resident's environment in nursing home and acute care, but also on their skin. This petri dish on the left-hand side of the slide is a handprint of someone that had just examined a nursing home resident with C. difficile. And the way that this is done is that we had the person put a glove on, touch the skin of the abdomen of a patient that had recovered from C. difficile, and then touch her hands to the petri dish. And the big fluffy yellow columns that you're seeing are C. diff. That's a huge number of C. difficile bacteria have been picked up after a 1 to 2 second touch of a person's skin. And you can imagine what happens, especially for nursing staff and nurses' aides who are helping people that have C. diff get bathed or change clothes or use the bathroom. A lot of personal contact and a lot of risk for acquiring C. difficile spores. One way that we can try to reduce the risk of transmitting C. difficile is to consider extending isolation. This is a graph that shows the time until negative results of C. difficile cultures from a resident's abdomen or their chest. So it's time in days along the x-axis on the bottom, and the proportion of people with C. difficile on their skin along the y-axis. So at the time when they still had just ended their symptoms of C. difficile, everybody had C. difficile on their skin. But even up to a week later, about half the patients in the study still had C. difficile on their skin, which means that we might need to wait for a week or longer until after someone's gotten better from their C. diff before we lift contact precautions. It doesn't mean they need to stay in their rooms, but it does say that when healthcare staff are interacting with them and helping them with ADLs and other activities, that we need to wear our gowns and gloves and to use soap and water upon exit from the room. And this is another study done by Housekeeping that led to asymptomatic carriers. And this is an older work, which is why we're using the term C. diff, which is C. difficile-associated diarrhea. Now we also say C. difficile infection. And along the x-axis, we've got patients with C. difficile infection in the first cluster of bars, asymptomatic carriers, and non-carriers. And the research team looked for environmental contamination in the rooms of people with these in these three different settings, three different states. And for people that have C. difficile infection, up to 80% had environmental contamination. That's the solid black bars. But for asymptomatic carriers, that was still 60%. And even for non-carriers, it was around 30%. So C. difficile is everywhere. And for a nursing home resident, when we say that there's no place like home, it becomes really challenging to clean this. Because people have all their belongings, their personal items, and we can't list everything here, which means that cleaning becomes a huge challenge. So steps that we can take in terms of infection control are to attempt first to minimize transmission by residents. So if there's a nursing home resident that we know or we suspect has C. difficile infection, they should, whenever possible, be in a private room. If that isn't possible, they can be cohorted with somebody else who may have C. diff. We have to encourage the residents to do hand hygiene with soap and water. We should talk about setting isolation and contact precautions based on the slide that I showed you just a couple slides ago. And also, and this is not evidence-based, but it makes sense, is for people that we know how to see this, have them use common equipment like they might use in physical or occupational therapy at the end of the day. And after they're done, then the people that use the physical and occupational therapist can use bleach or other sporicidal agents to really wipe down the equipment and get it clean so it's fresh and ready to go the following day, and they're not in a rush for time to get the next clothes in for their appointment. That was a tip I learned from one of my local nursing homes here in Cleveland. Other steps that we can take for infection control and minimize transmission by staff. Hand hygiene with soap and water is the best way that we have to reduce the transmission of spores by healthcare workers. Difficile spores are really sticky on skin. They're hard to wash off. And the soap does an okay job of using them, but it's still not 100% effective. What does seem to make a difference is the mechanical action of rubbing our hands together while there's soap on there and then running them under water and basically washing the feet down the drain. Other ways that staff can help reduce the risk of transmission is to make sure that we're all using single-use and disposable equipment. So glucometers and thermometers should only be used for one person or should be wiped out in between. Whenever possible, dedicated equipment, and I'm taking care of our blood pressure cuffs and flame, so that one person has their own flame when they're being moved around, and that can get laundered and then brought back to that person when necessary. And before it goes on to being used for a new person, it should also be laundered. And then also mandatory education, at least annually for our staff, and more often, especially for high turnover staff, like nurses aides that sometimes have an average work length of like 6 months at a facility. So with the constant or frequent turnover of staff, it can be hard to maintain kind of an institutional or cultural knowledge of what are good infection control practices. So they may need a refresher as often as every quarter. And it can be 10 minutes. Other things that we can do for infection control to minimize transition by staff is to maintain good contact precautions, and this means gowns and gloves. It's worth reviewing how to put these on and take these off. I've seen some very creative uses of gowns. It's a person being up over somebody's chest and going down and doing the full closure on their sleeves and left going over top, creating that full barrier. I've seen people just wear the gowns around their waist like it's a apron. I've seen people wearing the gowns around their gloves. And some other odd things that you wouldn't expect. So one thing that we can do is, in addition to educating the staff on how to use the personal protective equipment, is to make sure the equipment is available at the door to the residence room, and to designate someone on every shift whose job it is to go around and replenish supplies. If the gowns and gloves aren't there, it makes a better part to put them on. And to have to go get them yourself every time also creates another barrier. And then finally, supplying the facility and making them available in regular common areas is to have disinfectant wipes with bleach. There are some wipes that may say they look like a brand that has bleach in it, but unless it smells like bleach and says it actually contains bleach, it won't be effective against C. difficile. So it has to smell like bleach to be effective. And those wipes can be used to clean down common equipment like keyboards or telephones or computers in nursing stations. They can be used to wipe down doorknobs and door handles, as well as our stethoscopes, for example, if we're leaving a room where we think someone might have C. difficile. So they're good things to have out and available, and they don't violate those regulatory bodies that don't want us to have liquid around. So bleach wipes are a nice thing to use. And finally, for infection control, we can minimize environmental reservoirs. And this means involving and educating housekeeping staff. I think the housekeeping staff don't often understand the value of their role in preventing infection by doing good cleaning. They can be encouraged and asked to do daily disinfection of high surfaces, which is where those wipes come in again. And it may be that if there is an increase in the rate of difficile at a facility, rather than go to an cleaning product, the first thing to do is to assess the adequacy of cleaning. And the way that some people do that is through by putting down a dye that glows under UV light or under a black light. And there's certainly some kits that can be done to do this. There's also laundry detergent, which is a lot less expensive, that can be made into a slurry and also applied to the surface that will also fluoresce under a black light. And I'm not sure which flavor Tide it is, but Tide is the one that will fluoresce a little bit. And that can be a cost-saving intervention for facilities to have cleaning. Just a word to know why. So if you do start assessing adequacy of cleaning using these kind of hidden shopper techniques where you're putting the spot down and then check you later, once the housekeeping staff catches on to this, they go out and purchase their own black light and also look to see where the dogs are. So you have to move those dogs around sometimes. And finally, if cleaning isn't working with the aids that are being used and after lots of education and coaching of the staff, then it may be time to clean and disinfect with oral-style agents like bleach. And for reasons that we mentioned earlier, people are not familiar with using that because it can be so caustic, but it is effective and may be what's necessary to help bring an outbreak under control. One of the questions that I'm often asked is about probiotics for primary prevention. There's a meta-analysis that was done that slightly favors probiotics. One of the concerns I have with probiotics is a lot like saying people are going to go to Europe. When we say probiotics, we don't know what the species are. There's not often control over how those strains may have drifted. We also don't know how many of them are alive when they're actually sold and then actually administered. Even if they're kept in the fridge, the longevity of these things isn't clear. So my analogy of probiotics and backpacking in Europe is that we can say we're going to give a probiotic, but we're not sure what it is. It's like saying I'm going to go to Europe and we don't know if you're going to go to Prague or to Portugal or to Paris. So they're all different things. And probiotics are often proprietary mixtures of bacteria. And the meta-analysis that slightly favored probiotics was based on trials that were well-controlled clinical trials, not based on kind of everyday use. Finally, there's also no FDA-approved probiotics other than two that we all might consume, which is yogurt and something called kefir, which is like a strong liquid yogurt. These are approved and regulated by the Food and Drug Administration. They don't have prior prescription, but we do know what the strain of bacteria is that's in them, and we also know that there's live bacteria in them. So nursing homes that I taught with have gone to putting a yogurt on somebody's tray every day. And it can be any of the yogurts that they have live bacteria in them. It doesn't have to be one of the special yogurts that they have live bacteria. Additional steps that we can take for infection prevention across the entire facility are to implement antimicrobial stewardship programs to reduce the risk of exposure to antibiotics, and that will reduce the risk of C. difficile. To do surveillance for C. difficile infection, it's hard to know if rates have changed if you don't know what the baseline is. So by knowing what the background rate is, if there's an increase or an outbreak or the appearance of one, then it becomes knowable and steps can be taken. Avoiding tests of cure, and also using a laboratory-based alert system so that if somebody has a positive C. difficile, it should be called or faxed or otherwise notified directly to someone at the facility, not kind of stuck on the computer or in a pile of faxes that shows up when they're about 3 days later. There needs to be a more active, proactive outreach of the notification, and that's what can be worked with a laboratory. Facilities, especially long-term care, may think about doing an early response to potential C. difficile infection. So this means defining criteria, which for most people is going to be at least 3 liquid stools per day. In other circumstances, especially if someone had either had a history of C. diff or recent exposure to antibiotics, doing preemptive contact isolation. It sounds a little mean, but I would rather see someone in isolation for 2 or 3 days without me than to have that same person who may currently have C. difficile become a source for having C. diff spores spread around the facility and putting a lot of other people at risk. And finally, I think there should be standing orders for nurses to to test or to initiate testing for C. difficile when specific criteria are met. And that's a policy that needs to be considered at an individual facility level. So to wind this up, the take-home messages are that metronidazole and oral vancomycin are still the mainstay of treatment. Fecal microbiota transplant is safe and effective, and as we move to an era where we're able to do this using freeze-dried capsules, it's much more palatable for people. And finally, infection control is especially challenging and especially important in post-acute and long-term care settings. I'd like to end by thanking everyone for listening, and I'd also like to thank you for the work that you're doing on the front lines to take care of our nursing home residents and our hospitalized patients, and to try to reduce the epidemic C. difficile infection. Thank you very much.
I hope that you all, this is Janet again, I hope you all enjoyed this informative video presentation, and we're going to move on to questions now. And we'll start with any questions that may have come into the chat line. Joyce?
Okay, we have what I suggest regarding employees who report allergies to bleach. I will not allow staff to substitute products for bleach patients for cleaning as that is what we have in formula. An EPA-approved, Untitled clean, purified, hypochlorite product that is registered. I usually suggest that they verify symptoms and, if needed, move that employee to another part of the building or switch patients. Is that sufficient?
I think that sounds like a very, just Janet again, I hope that sounds like a very good approach. There are other products, non-bleach containing, which can be used, but they may have a longer dwell time than the bleach product has. So I think that the approach that you're taking, where you're trying to, and you need to work this out with your Human Resources Department, certainly with some medical opinion also about the allergy, and I think you're also going to have to take it on a case-by-case basis how this can be worked out. I am not aware of any literature that is showing a high number of people with bleach allergies.
Okay, and from Nadine Rhino, we use an electrostatic spray gun that is proven to kill C. diff in our facility. It does not use bleach.
I have seen that demonstrated at trade shows. I will have to say that I am not aware of all of the efficacy studies that are done. I believe that if you're using that type of a product, you would want to make sure from the manufacturer that you have literature backup for how effective it is. And more specifically, that they can show you repetitive studies, not just one study, but repetitive studies that have been done to show the effectiveness of that. And I'm not saying yay or nay about it, because I know there are a number of facilities that are using that. Just keep in mind that the spore itself is very sticky, as the presentation said, and that you would want to make sure that not just everything in the environment, but remember what they were saying here too about how long the spores actually can be on somebody's person. And we probably wouldn't be using bleach wipes or an electrostatic product on the patient. So again, if you're going to be using that type of a product, let's make sure you have good backup and that you feel very comfortable with the effectiveness of it.
We have nothing else in chat at the moment.
Something that I would add, Dr. Jump mentions the guidelines from the Infectious Disease Society of America and that they are being updated. I did check last week. As of last week, there was not an updated version available yet, but I also have read that those are due out very soon. Is there anyone who wanted to call in with a question or has a question?
To ask a question over the phone, please press #6 to unmute your line.
Hello, my name is Bruce. Hi, I was wondering, is there any way to get a synopsis of what was spoken about today? Only because I was interrupted several times. I'm sorry, I tried not to let that happen, but it did.
Actually, we will be sending, Janet, I can take this one for you. We will be sending out an email tomorrow that will contain a link to the presentation and then also to where you can find a copy of the recording so you can go back and listen to the parts that you may have missed.
Okay, so we can...
It sounds like somebody's unmuted themselves, so if you guys can just make sure you're on mute if you are not asking a question. We want to make sure to get everybody's questions.
All right, so I'll receive an email with a link to be able to review this again?
That is correct.
Thank you very much. I think that the seminar was wonderful and very informative. Thank you.
Excellent. Janet, did you have anything else to add? I didn't know if there was maybe a synopsis from the original presentation.
Well, that's what I was going to say. Bruce, if you wanted to put your email, I guess, can he put it in chat? Because there is actually a transcript of this that I can find and that I think I can send him, I might be able to send a link to him for that.
Oh, that would be great. That would be great. Okay, so I'll just go in here and go into chat.
And I'm not sure how this works. Can he send that to Joyce in chat? Yes. Oh, okay. All right.
Okay.
Are there any other questions? All right, if there aren't any other questions, just a couple more slides to go through. If you decide you have questions later, here's a list for you of the Clostridium difficile lead in each of the 6 New England states, and you can contact them with your question and somebody will get back to you. We'd also like you to mark your calendars with upcoming collaborative and partner events and educational opportunities. Let me do a plug here for the January 4th webinar. It's sort of a continuation of this webinar. We actually are going to have speakers from Athena Healthcare Corporation, and they're going to talk about their Clostridium difficile policies and how they implement it in their nursing homes. So it would be a real boots-on-the-ground presentation, and we're excited about that. And you can always check out our website for more information or contact your state lead if you need help registering for any of the programs. The Learning Center is our virtual learning system. It hosts free courses for all healthcare settings. Our goal is to educate providers and help them improve the quality, efficiency, and value of healthcare. You can create an account by visiting learningforquality.org. You'll be able to find the registration code for your healthcare setting. And if you have any questions about the Learning Center, send an email to learning@healthcenteradvisors.org, which is on the screen there, and somebody there will be very glad to help you out. The Patient and Family Advisory Council that we operate partners with healthcare professionals to make a difference in patient care. If you know anyone who would be interested in serving on this council, please contact Russ Cooney. You'll see his contact information on the screen, or you can visit our website for more information. Don't forget to follow us on social media to get important alerts, news, and more. Thank you very much for joining, and we hope you all have a great day. Thanks.
Thanks, Janet.
The leader has disconnected. The conference will be terminated in 5 minutes.